First of all, I would like to thank Jyotidev sir and the team for giving me an opportunity to present this topic. Coming to the topic proper, female sexual dysfunction in diabetes. I'll be discussing under the following headings. In a study of women's health, more than 75% of women reported that sex is moderately to extremely important component of human life. And the normal sexual response include desire, arousal, and orgasm. Masters and Johnson's model of sexual response cycle shows excitement, plateau, orgasm, and resolution. And this is again diagrammatic representation where you can see that in females multiple orgasm can be possible. And in Bassen's nonlinear model of female sexual response emphasized that emotional intimacy is an essential component of female sexual arousal and orgasm. There are various hormones and neurotransmitters involved in proper functioning, sexual function. Estrogen, oxytocin, progesterone, testosterone, all these have got positive impact on various aspects of sexual response cycle like arousal, desire, etc. Whereas prolactin has got a negative impact on arousal. And various neurotransmitters also like dopamine, nitric oxide, all these has got positive impact. Coming to female sexual dysfunction, sexual problems are least addressed in day-to-day clinical practice. The WHO definition of female sexual dysfunction says that the various ways in which a woman is unable to participate in sexual relationship as she would wish constitute female sexual dysfunction. The clinical definition is the persistent or recurrent decrease in sexual desire or arousal, the difficulty or inability to achieve an orgasm, or a feeling of pain during sexual intercourse constitute female sexual dysfunction. It's associated with multiple risk factors like biological, medical, psychological, and social factors. Depending upon the stage of sexual response cycle, the female sexual dysfunction can be divided into female sexual interest or arousal disorder where desire or arousal is affected, female orgasmic disorder where orgasm is affected, and genitopelvic pain or penetration disorder where there is pain or discomfort associated with sexual activity. The female hypoactive desire disorder and female arousal disorders, the older classification is merged into a single entity called female sexual interest arousal disorder, and dyspareunia and vaginismus is merged into a single entity called genitopelvic pain penetration disorder in the newer classification. Diabetes mellitus is a common metabolic disease. Its prevalence is increasing worldwide. It's associated with both acute and chronic complications. The chronic complications include vascular and non-vascular complications. Coming to female sexual dysfunction in diabetes, the global prevalence of sexual dysfunction in women with diabetes varies from 20 to 80%, and various studies showed the percentage of various disorders like desire disorder, arousal disorder, orgasmic disorder, etc. Coming to the pathophysiology of sexual dysfunction in females, as we all know, diabetes mellitus is associated with hyperglycemia, which precipitate genital infection and which can cause dehydration and vaginal dryness. All these can lead to sexual pain or discomfort. Hypoglycemia induce irritability and fatigue, reduce the desire, and vascular complications and neurological complications reduce the arousal and it impair the sexual functioning of the female. Similarly, associated comorbidities, psychological distress, all these impair the arousal and desire, leading to female sexual dysfunction. Hormonal issues like reduced estrogen and androgen level also leads to female sexual dysfunction. Coming to the clinical presentation, the female may present with a decrease or loss of desire, inadequate vaginal lubrication, inability to achieve orgasm, or inability to relax the vaginal muscles enough to allow intercourse, or pain during intercourse, which constitute various female sexual dysfunctions. In a patient with female sexual dysfunction, proper history including medical, sexual, and psychosocial history is important. Complete examination including pelvic examination and routine investigation plus hormonal assays and pelvic ultrasonography is usually done. So history is most important. In addition to the history of presenting symptom, we have to consider the socio-demographic factors, history of sexual problem, nature of general relationship with the partner, psychosocial and psychiatric issues, life stresses, medical history, contraceptive history, menstrual history, and attitude towards the problem and attitude towards the intervention. And it's also very important to get a proper history from the partner, because partner can also be an important source of information. So we have to differentiate, is it lifelong or acquired, is it global or situational, and can the patient attribute a certain event to the onset of complaint. There are various medications which influence or which decreases the sexual response, like anticonvulsants, hormonal medications, psychotropic agents, cardiovascular drugs, etc. There are a lot of well-validated questionnaires to assess the female sexual function, like female sexual function index, brief index of sexual functioning for women, etc. And these are the various questions in female sexual function index. There are 19 questions, and first 2 questions indicate the desire, 3 to 6 questions arousal, and other 7 to 10 lubrication, and 11, 12, 13 orgasm, and the other 3 questions about the satisfaction, and last 3 questions about the pain during sexual intercourse. There are well-established models for addressing sexual health issues with the patients. The 2 well-established models are the PLICIT model, where the letters stand for permission, limited information, specific suggestion, and intensive therapy. And ALLOW model, where it stands for ask, legitimize, limitation, open up, and work together. A complete physical examination and genitopelvic examination is essential. Depending upon the examination findings, we may get the probable reason for the sexual dysfunction. Like if there is cystocele or rectocele, it can cause decreased desire or dyspareunia. If there is retroverted uterus, it suggests endometriosis, and there can be deep dyspareunia. If there is loss of pubic hair, it indicates low androgen level. Again, it can reduce the desire. If there is hypertonicity of pelvic muscles, it may indicate vaginismus, and it can lead to dyspareunia. Similarly, if there is thyroid enlargement, it may indicate hypothyroidism, which can again cause reduced desire or arousal. Coming to various conditions, female sexual interest and arousal disorder, we have to rule out other causes like relationship issues, depression, medication, thyroid disorders, vascular disease, prior pelvic surgery. Those with orgasmic dysfunction, lack of stimulation, arousal disorders, various medications, all these have to be considered. And those with genitopelvic pain, penetration disorders, we have to consider vulvovaginal atrophy, endometriosis, various genitourinary causes, vaginismus, pelvic inflammatory disease, ovarian disease, etc. And genitopelvic pain penetration disorder can be superficial or deep pain. And coming to the investigation, in addition to the complete blood test, hormonal assays including thyroid profile, prolactin, adrenal hormones, then sex steroids including estradiol, progesterone, and testosterone, liver function test, and pelvic or transvaginal ultrasonography is usually done depending upon the clinical scenario. And there are a lot of other advanced investigations like vulvoscopy, vaginal photoplethysmography, vaginal magnetic resonance imaging. All these are usually done under a research setting. Coming to the diagnosis, for diagnosing female sexual dysfunction, the symptom has to be there for at least 6 months, and it causes significant distress to the individual, and it is not better explained by other conditions. For female sexual interest or arousal disorders, there is lack of or significantly reduced sexual interest or arousal. And orgasmic disorder, there is decreased delay or marked infrequency or absence of orgasm or reduced intensity of orgasm. And genitopelvic pain penetration disorder, there will be difficulty in vaginal penetration or pelvic pain during intercourse, or fear or anxiety about penetration, or marked tensing or tightening of pelvic floor muscles. The newer classification consider vaginismus and dyspareunia as a single entity as genitopelvic pain or penetration disorder. But there are a lot of difference between those 2 conditions, and we propose a diagnostic criteria for vaginismus, which include subjective criteria, objective clinical and laboratory criteria, frequency duration criteria, and exclusion criteria. In the subjective criteria, there is persistent and recurrent difficulty or inability to allow vaginal entry of penis, fingers, or any other object despite the express wish of the female partner. And objective criteria, there is muscle spasm during vaginal examination or attempted penetration. And laboratory criteria, demonstration of increased muscle tone in EMG during attempted penetration, and frequency duration criteria, it should persist more than 6 months with most of the time, majority of the attempts, that is more than 50%, and it should not be due to any other cause, that is exclusion criteria. And depending upon the presence of subjective criteria, objective criteria, frequency duration criteria, you can see that if all are present, it is typical of vaginismus. If frequency duration criteria is not there, so it is transient vaginismus. If there is associated features of dyspareunia, it comes under vaginismus dyspareunia overlap syndrome. Coming to the treatment of FSD is a challenge because of lot of reasons like lack of single causative factor, limited proven treatment options, and the non-pharmacological therapies include control of blood sugar, control of other risk factors and comorbidities, diet control and exercise, etc. And there are a lot of non-pharmacological treatment options. And in patients with hypoactive sexual desire disorder, the pharmacological treatment include testosterone, topical or systemic estrogen, phosphodiesterase inhibitors, flibanserin, etc. In patients with sexual arousal disorder, sex education, use of phosphodiesterase inhibitors, lubrication, clitoris therapy device, all these are the treatment options. In those with orgasmic disorder, penetrative or non-penetrative vibrating sex aid, cognitive behavior therapy, sensate focus, phosphodiesterase inhibitors, all these are the treatment option. In those with sexual pain disorders, first we have to find out what is the cause and we have to treat the underlying causes. Then there are a lot of non-pharmacological treatment options like cognitive behavioral therapy, systemic desensitization, etc. In postmenopausal vulvovaginal atrophy, we can use vaginal lubricants or systemic hormonal therapies or estrogen therapy or oxymethicin for dyspareunia. And omega-3 fatty acids also improve sexual function in females. Testosterone is usually used for hypoactive sexual desire disorders in postmenopausal women. DHA improve the frequency of sexual thought, sexual interest, and sexual satisfaction. The vaginal estrogen therapy, different forms are available, creams, rings, and vaginal tablets are available. Phosphodiesterase 5 inhibitors increase the blood flow to vagina, clitoris, and smooth muscles of the labia, increasing sexual arousal and lubrication. This is a study demonstrating that the lubricants and moisturizing agents reduce the vaginal dryness, thereby helping to reduce dyspareunia. It can be either water-based, silicone-based, or oil-based. And flibanserin is another drug which is a serotonin 1 receptor agonist and serotonin 2A receptor antagonist used for generalized acquired hypoactive sexual desire disorder in premenopausal women. Tibolone reduces hot flashes. It has got positive effect on vaginal dryness and it improves the desire. Yohimbine also reduces the threshold for excitability in the forebrain centers. And bremelanotide is a melatonin receptor agonist with non-selective activity on melatonin receptor 1 to 5. It's used for the treatment of hypoactive sexual desire disorder. Bupropion is used to treat SSRI-induced sexual dysfunction. It significantly improves the desire and reduces the distress. Alprostadil is a potent vasodilator. Local application improve the vaginal blood flow and improve the arousal. Ospemifene is a non-selective estrogen receptor modulator. It's useful in the treatment of vulvovaginal atrophy and dyspareunia in postmenopausal women. And in postmenopausal women, estrogen deficiency causes physiological changes of the vaginal epithelium like thinning, narrowing, reduced elasticity, and increased vaginal pH, leading to vulvovaginal atrophy, dyspareunia, and vaginal dryness, which is called genitourinary syndrome of menopause. And oxymethicin exert estrogen agonistic activity on the vaginal epithelium, thereby help to reduce these issues. And the Eros stimulator or the clitoral device is used to treat female sexual dysfunction, hypoactive female sexual dysfunction. So to conclude, sexual dysfunction is common among women with diabetes. Treatment of FSD requires a multidisciplinary approach. Optimal glycemic control is the key component in the management of FSD in diabetes. And I have got an opportunity to contribute a chapter on this textbook on management of diabetic complication, where we contributed a chapter on sexual dysfunction in people with diabetes. Thank you for the patient listening.
Thank you, dear Raveendran sir. Presentation and the topic being the area where in our clinics or the routine practice, maybe patients are not revealing the exact fact with the treating physician or diabetologist, but things are changing. We are seeing many a times ladies are complaining or explaining the discomforts they are having while managing diabetes. So I think you were covering a vast area with regard to female sexual dysfunction. So what's the ratio, what's the percentage of patients you are seeing among your diabetes patients?
Female patient comparatively less. I used to get female patient just because my wife is a gynecologist, and when the couple with infertility and other issues goes to them, she sends the patients to me, and the gynecological part is managed by her.
Okay.
So I don't have much experience in managing these cases, and the exact ratio I cannot tell this because patients are not directly coming to us.
Any questions from the audience?
The prevalence of sexual dysfunction is more in people with diabetes compared to non-diabetic.
What extent is the difference?
What extent I don't know exactly, sir.
And I think you have discussed so many drugs towards the end. So are these drugs all are being used?
I don't know about here. There we are not using all these drugs.
Any other
I think
comments?
Jumani sir will be able to.
Yeah. I think during the talk he will be discussing that. So thank you, Raveendran sir.
Okay, thank you.
So we'll move on to the next topic.